So hi guys, today we are going to start with a new video known as disorders of eyelid, which comes under the subject ophthalmology. So in disorders of eyelid, in this video we'll go for another different approach. We will see clinical cases, and through those cases we'll go to the disease in detail. But before going for disorders of eyelid, first we will discuss about the basic anatomy and applied anatomy of eyelid. So eyelids are basically the mobile tissue curtains which are placed in front of the eyeballs, and they act as shutters protecting the eyes from injuries and excessive light. Also perform an important function of spreading the tear film over the cornea and conjunctiva, and they also help in drainage of tears by the lacrimal pump system. So what are the parts of eyelid? In eyelid is divided by a horizontal furrow into two parts, the orbital part and the tarsal part. So over here you can see that's the orbital portion and that's the tarsal portion. The upper eyelid covers 1/6 of the cornea and the lower eyelid just touches the limbus. Then there is the lid margin, as you can see over here. The lid margin is present, which basically divides the punctum into two parts, the upper punctum and the lower punctum. And basically there are two canthus, medial and the lateral canthus. So basically that's the medial canthus, which you can see over here. There's the medial canthus and this is the lateral canthus. Then this canthus divides, and the puncta divides eyelid margin into two parts. Medial lacrimal portion, that's the medial lacrimal portion, and the lateral ciliary portion. So medial lacrimal portion is rounded and devoid of lashes and gland, and lateral ciliary portion is basically sharp posterior border, rounded anterior border, and in between the two borders there is an intermarginal strip. Now in detail about the structure of the eyeball covering eyelids. So basically it consists of 5 layers. First being the skin. Skin is the most elastic, has a fine texture and thinnest in the body. Then is the subcutaneous areolar tissue. It's a loose connective tissue containing fat, no fat. It is readily distended by edema of blood. That is clinical importance. The third is a layer of striated muscles. It consists of orbicularis oculi muscle, which forms an oval sheet across the eyelids and comprises of three portions: orbital part, which encircles the orbital margin, preseptal part and pretarsal part, as you can see in this thing. So what is the significance of this orbicularis muscle? As it closes the eyelid and is supplied by zygomatic branch of facial nerve. Therefore paralysis of facial nerve occurs lagophthalmos, which may be complicated by exposure keratitis. Next layer of muscle is levator palpebrae superioris muscle, LPS muscle basically. Next is a submuscular areolar tissue. In this layer all the nerves and vessels lie, because of which this layer is considered as to anesthetize the lids. Then we have a tarsal plate, fibrous layer, which comes in fibrous layer. It's a framework of lid and consists of two parts: central tarsal part and peripheral septal orbitale part. Then we have a layer of non-striated muscle fibers, which consist of palpebral muscle of Mueller, which lies deep into the septum orbitale in both the lids. And last we have conjunctiva. So this is basically the clinically significant gray line talking about rheolan muscle, which is anterior to the tarsal plate, divide the intermarginal strip into anterior strip bearing lashes in 2 to 3 rows and posterior strip which bears the meibomian glands. And these meibomian glands are important gland of eyelid. Other glands are also present, we will see them now. So in other glands you have glands of Zeiss. It's a sebaceous gland which open into follicles of eyelashes. Glands of Moll, it's a modified sweat gland which is near the hair follicle. And we have accessory lacrimal gland of Wolff's present near the upper border of tarsal plate. Then we will discuss about few congenital anomalies. First being the congenital coloboma of upper eyelid. What does this mean? It is a rare condition characterized by a full thickness triangular gap in the tissues of the lid and the anomaly usually occurs near the nasal side and involve the upper lid more frequently than the lower lid. Treatment consists of plastic repair of the defect. Here you can see cryptophthalmos. It's a very rare anomaly in which lid fail to develop and the skin passes continuously from the eyebrow to cheek, hiding the eyeball. Then we talk about congenital ptosis. It's a common congenital anomaly, and congenital coloboma we discuss. Epicanthus. It's a semicircular fold of skin which covers the medial canthus, and it is a bilateral condition may disappear with the development of nose, and it is a normal facial feature in Mongolian races, and it's the most common congenital anomaly of the lids. Treatment consists plastic repair of the deformity. Then we have few terms like microblephron and epiblephron. Micro means small, so basically eyelids are abnormally small, and blephron stand for the term eyelid. It's usually associated with microphthalmos or anophthalmos. Occasionally, the lids may be very small or virtually absent, and the condition is called as a ablephron. Then we have epiblephron, which refers to congenital anomaly in which a horizontal fold of tissue rides about the lower eyelid margin, and it usually disappears with growth of face and needs no surgical correction. Then we have euroblephron, that is unilateral or bilateral horizontal widening of the palpebral fissure, and it is usually associated with lateral canthal malposition and lateral ectropion. Ectropion means basically outward turning of the eyelid, and congenital euroblephron usually involves the lateral portion of lower eyelid. Then we have congenital ankyloblephron. It's a rare anomaly in which single or multiple strands of connective tissue joins the upper and lower lid margins anywhere but never at the medial and lateral canthi. And such a congenital ankyloblephron is also called ankyloblephron filiforme adnatum. It should be surgically divided to prevent amblyopia. Then we have congenital entropion and ectropion, which we'll be seeing afterwards. Now let's talk about the next topic, which is edema of eyelids. So basically in edema of eyelid we have divided into three parts: inflammatory edema, solid edema, and passive edema. So basically talking about inflammatory edema is seen in following condition like inflammation of the lid itself, which include dermatitis, stye, hordeolum internum, insect bite, cellulitis, and lid abscess. Inflammation of conjunctiva such as acute purulent membranous and pseudomembranous conjunctivitis. Inflammation of lacrimal sac such as acute dacrocystitis, adenitis. Then we have inflammation of eyeball like acute iridocyclitis, endophthalmitis, and pseudoophthalmitis. Inflammation of orbit, which include orbital cellulitis, orbital abscess, and pseudotumor. Inflammation of paranasal sinuses, example maxillary sinusitis. Then we have solid edema, which is basically chronic thickening of lids which follows recurrent attacks of erysipelas. It's harder in consistency than the inflammatory edema. Then we have passive edema, which has local causes and general causes. In local causes, we have cavernous sinus thrombosis, head injury, and angioneurotic edema. In general causes, we have congestive cardiac failure, hypoproteinemia, and severe anemia. Now we talk about blepharochalasis. It's basically a rare condition characterized by two phases: active phase of episodic inflammation of the eyelid and quiescent phase of boggy eyelid skin fold. What is the common etiology? Exact etiology is not known, but it may be a variant of angioneurotic edema, or it may be puberty or hormonal changes which play the modulatory role. An association with Ascher syndrome in which the upper eyelid and lip become swollen, and pathological characteristics finding reported is lymphocytic infiltration of the dermis and loss of elastic fibers. Next we talk about is the clinical features, in which we have two types: active phase of episodic inflammation of eyelid, which involves recurrent attack of inflammation occurring in both upper and lower eyelids. Then we have pubertal age, common in both male and female. Non-pitting edema, which lasts for 2 to 3 times a day. Next we have a quiescent phase of baggy eyelid folds, in which there is a cigarette paper skin, thin and finely wrinkled appearance. Then we have can occur in lid laxity and pseudoepicanthal fold formation. And basically entropion and ectropion, orbital fat prolapse, lacrimal gland prolapse. Then there is a treatment for surgical phase. We have blepharoplasty. Then we have basically levator aponeurosis dehiscence repair, and we have eyelid tightening and canthal tendon reattachment. Now we come to our main topic, that is inflammatory disorders of eyelids, in which we have classified as disorders affecting the lid margin and disorders affecting eyelid glands. So disorders affecting lid margin include blepharitis, in which there is an anterior and posterior division. In anterior we have bacterial ulcerative, squamous and mixed staph plus seborrheic dermatitis, and in posterior we have a parasitic blepharitis. In eyelid gland we have hordeolum, external and internal hordeolum. External hordeolum also called as time. Then we have chalazion, and we have molluscum contagiosum, which causes the disorder of eyelid glands. Now, as I told up till here, applied anatomy, structure, and basic other disorders of eyelids, non-inflammatory we can say, were discussed. But now we'll discuss about the inflammatory disorders, and it will be discussed in a certain different way. First, we'll take up a case. We'll take up a case of a patient and its history, and according to history, we'll dig up to the diagnosis, and then we will discuss about the disease in detail. So first, let's see which case comes. So the first case I'm discussing is of basically common in children and common in both sexes, male as well as female. The patient is complaining about deposits at the lid margin associated with irritation, discomfort, occasional watering, and that is epiphora, and history of falling of cilia or glowing of cilia. Now, after taking up the basic age and sex and presenting symptoms, we went for ocular examination, and this ocular examination revealed certain signs. What were those signs? Those were basically accumulation of white dandruff-like scales on the lid margin. On removing these scales, the underlying surface is found to be hyperemic, that is no ulcers. Lashes fall out easily. In long-standing cases, lid margin is thickened and sharp posterior lid border tends to be rounded, leading to epiphora. So basically these were the signs of seborrheic blepharitis. Another case was there in which the signs were like yellow crust are seen at the root of cilia, which glue them together, and small ulcers which bleed easily, as seen upon removing the crust, and in between the crust anterior lid margin may show dilated vessels, that is rosette formation. So basically, after understanding this description, what is the probable diagnosis? It's blepharitis, that is a case of blepharitis, inflammation of the eyelid margin. So what is blepharitis? We'll answer the questions. Blepharitis is basically a chronic inflammation of lid margin, and it can be divided into 4 classical types. Those 4 classical types are seborrheic as squamous blepharitis, ulcerative blepharitis, mixed ulcerative and seborrheic blepharitis, posterior blepharitis, or meibomitis. Now let's talk about the bacterial blepharitis. It starts in childhood, and anterior part of lid margin is targeted. Other cause, then the main etiology as Staphylococcus aureus, Coagulase positivus, Streptococcus propionibacterium, and Moraxella. Talking about the clinical features, symptom, it include chronic irritation, itching, mild lacrimation, mild photophobia, and glowing of cilia. Signs, yellow crust, small ulcers, red thickened lid margin, mild papillary conjunctivitis, and conjunctival hyperemia. Talking about complications, it's lash abnormalities like medrosis, trichiosis, poliosis, stylosis, then eversion of punctum leading to epiphora, and if the epiphora is prolonged, it will lead to eczema of skin and ectropion. Recurrent stye is common complication, and secondary inflammatory changes and mechanical changes may occur in cornea and conjunctiva. So now let's discuss how to treat this condition. So basically, to treat a case of squamous blepharitis, Scales should be removed from the lid margin with the help of a lukewarm solution of 3% soda bicarbonate or some baby shampoo. Combined steroid and broad spectrum eye ointment should be rubbed at the lid margin twice daily. Associated seborrhea should be treated adequately. Now next is seborrhea or squamous blepharitis. As we discussed the treatment beforehand only, we can see that what the etiology is basically seborrhea of scalp, that is dandruff. Glands of Zeiss secrete abnormal excessive neutral lipids which are split up by Corynebacterium acne into free fatty acids. Talking about clinical features, symptoms are soft scale at lid margin, mild discomfort and irritation, history of falling eyelashes and occasional watering. Signs of white dandruff like scale at lid margin upon removal, eyelash hyperemic and greasy, rounded posterior border, epiphora, lash followed easily but replaced. Complications are same as ulcerative blepharitis as we discussed. And talking about the treatment, as we discussed early only, talking about treatment of ulcerative blepharitis, that is hot compress. Crust should be removed after softening with 3% soda bicarb. Antibiotic treatment should be applied at lid margin immediately after removal of crust. Then antibiotic eye drop should be instilled 3 to 4 times a day. Then oral antibiotics such as amoxicillin, cloxacillin, erythromycin or tetracycline may be useful. Now an important question, how to differentiate between squamous blepharitis from ulcerative blepharitis. So basically in squamous blepharitis, white dandruff like scales are seen at the lid margin, while in ulcerative blepharitis, yellow crust are seen. That's the first difference. Second is, on removing the white scales, underlying surface is found to be hyperemic in squamous blepharitis, while in ulcerative blepharitis, small ulcers which bleed easily are seen upon removal of crust, and cilia may be glued together in ulcerative blepharitis, but that doesn't happen in squamous blepharitis. Now we will talk about posterior blepharitis or meibomitis, that is inflammation of the meibomian glands. Meibomian glands are present at the sharp posterior border, that is behind the intermarginal strip. So meibomitis occurs in two forms, chronic and acute form. Chronic is basically commonly occurring meibomian gland disorder in middle-aged person with acne, rosacea or seborrheic dermatitis. What are the clinical features? Symptoms are worse in morning. They include chronic irritation, burning, grittiness, itching and mild lacrimation. Signs are foamy secretion on eyelid margin and canthi, white yellowish streaks and shining through conjunctiva, hyperemia and telangiectasia of posterior lid margin. Secondary changes: inferior corneal punctate erosions and papillary conjunctivitis, oily and foamy tear film with froth accumulation at lid margin, orifice showing capping with oil gland pouting and recession or plugging, then opening of meibomian gland prominent with thickened secretions, that is toothpaste appearance. So this is a sign of posterior blepharitis. Chronic meibomitis. Now talking about acute meibomitis, etiology is staphylococcus infection, pressure, expression of perspirate followed by serosanguinous discharge. Now I'll discuss about parasitic blepharitis. Is basically infestation of flashes by lice in poor and hygienic condition being the predisposing factor. Then Theriasis palpebrum by crab louse in adult with STIs, and pediculosis, head louse, Demodex blepharitis, which is caused by Demodex follicularium anterior and Demodex brevis posterior blepharitis. Talking about clinical features, with the chronic irritation, itching, burning and mild lacrimation. Signs include lid margin are red plus inflamed, that is hyperemic and inflammation, lice anchoring lashes with closed base of cilia. Then we have basically nits, opalescent pearls adherent to base of cilia. Then we have conjunctival congestion in long-standing cases. Treatment include mechanical removal, yellow mercuric oxide 1% lid margin and delousing. So these were basically about the disorders which includes the eyelid margin. After this, all the disorders which will be discussed, that is external hordeolum or stye, chalazion, then basically chalazion, then internal hordeolum. Then after it will come to eyelash disorders, which is the third part, that is trichiasis, in detail dyschiasis, trichomegaly madrosis. Then we'll go for anomalies in position of lid margin, which are the important ones, such as entropion. Then we have ectropion, which is another one important. And then we have is the ptosis. Then we have basically blepharospasm, blepharopimosis, lygophthalmos. These all disorders will be discussed in detail. After that, we'll also have a short recap of tumors of eyelids. So basically, in this video only we were talking about basics, applied anatomy and disorders of eyelid margins, but in next video, which will be a bigger one, it's going to be in detail about rest all of the aspects of eyelid disorders, that are eyelash disorders and also tumors and everything. So basically this series of ophthalmology second video this was, and now the third video will also come soon. Stay tuned. Thank you for coordinating.